Hey again, I'm Anna with NCLEX Reviews. Today we'll take a look at some basic facts about two classes of antihypertensives that you should definitely be familiar with for your NCLEX exam and even for your nursing career, which will be starting right around the corner. According to the CDC, nearly half of American adults have hypertension. That's a lot. And we have a few medications that can be used to treat hypertension. But the two classes we'll talk about today, calcium channel blockers and beta blockers, can also be used for other conditions like arrhythmias or even to aid in the treatment of migraine headaches. But for today, let's focus on what they do to the heart and consequently the blood pressure. Let's start with calcium channel blockers. These are considered some of our go to antihypertensives. These drugs often end in dipene, like amlodipine or nifedipine, but there are two notable exceptions to that: verapamil and diltiazem, and we are going to cover those in just a little bit. But first, let's talk about how calcium channel blockers work. So, calcium channel blockers, well, they work by blocking calcium entering the heart, and calcium does what? Well, calcium increases contractility in cells. So, calcium enters the heart, causing vasoconstriction and driving up the heart rate and blood pressure, which allows it to squeeze harder. So, this class of drugs will actually block the calcium channels in the cardiac muscle, and instead, it'll cause vasodilation and relaxation of the coronary and peripheral arteries. So, this will help drive down blood pressure, drive down heart rate, decrease contractility, which is how hard the heart muscle squeezes, as well as decrease conductivity, which is those electrical impulses. The vasodilation is also handy for conditions like angina or chest pain. Now, I did mention two notable categories of calcium channel blockers. We have our dihydropyridines or DHPs and our non dihydropyridines or non DHPs. So the dihydropyridines end in dipene, like nifedipine, amlodipine, nicardipine, and these work primarily in the peripheral vessels, causing vasodilation. They have less effect on heart function. Now, the non DHPs, on the other hand, have more of a direct effect on the myocardium or the heart muscle itself, and consequently, they affect cardiac function greater. So, non DHPs directly affect the pulse or the heart rate, bringing it down. So, examples of these non DHPs are going to be our verapamil and diltiazem. And do you want to know an easy way which I remember which are which? So, our dihydropyridines end in dipene, right? And the non dihydropyridines have no pene, and it's right there in the word itself. All right, let's go ahead and jump to some side effects and other nursing considerations for these drugs. What side effect might you see with this vasodilation effect? Well, we may see a headache with these. What are some things that would make us want to call the provider to hold the medication? We absolutely need to be careful when clients have bradycardia or certain heart blocks or even other conductive issues, as these drugs, remember, they impact that contractility. And speaking of contractility, what's another condition that affects how the heart pumps? Heart failure, absolutely. Especially these non DHPs like verapamil and diltiazem, which if you remember, have a greater impact on heart function than the DHPs. So, calcium channel blockers contraindicated in clients with heart failure because they can negatively impact cardiac output and also due to one other big side effect: peripheral edema. So, due to that vasodilation caused by these medications, edema is a huge risk. And which clients already have concerns with edema and fluid overload? Clients with heart failure. So, here is a fun little memory trick for you all. One of my favorite ways to remember this for the calcium channel blockers is by thinking of all the D's. So, dipenes act distally through vasodilation and can cause edema. All right, before we move on, here is some bonus information to review while we're on the topic of heart failure. What are some objective findings on a physical exam in a client with heart failure? Can you remember? If you recall, heart failure often leads to volume overload. So, what would we expect to see with volume overload? We could potentially visualize the client being short of breath, hear crackles on auscultation, see swellings in the hands, feet, ankles, and weight gain due to that fluid overload. So, what is something we want to monitor in clients who have heart failure? Intake and output are very important to closely monitor in these clients. And very, very important here, we also ask the client to obtain daily weights. This is so we can see how much fluid they are intaking and releasing, assessing fluid volume. Now, how much weight gain would be concerning to the nurse with a client who has heart failure? A weight gain of more than 2 pounds in a day definitely would need some further intervention. All right, let's move on to our next class. So, our next class of antihypertensives we are going to take a look at is a class that isn't as commonly used first line for hypertension anymore. That's our beta blockers. These drugs are all going to end in LOL. Some examples include metoprolol, atenolol, propranolol, labetalol, and while these might not be used as frequently for hypertension, we do see them used frequently to help with symptoms of anxiety or hyperthyroidism. They're also used in a specific client population for hypertension. Do you remember? Those who are pregnant. Propranolol, especially, is one of those pregnancy safe antihypertensives. Do you remember how beta blockers work? They can help reduce the blood pressure by making the heartbeat slower at a slower rate and with less force. So, lower blood pressure and lower heart rate. So, what is being blocked then with beta blockers? Well, this medication is going to be blocking those beta receptor sites. So, epinephrine and norepinephrine can't bind there. This blocks what we'd call a sympathetic response. And do you remember the other name for that? Fight or flight. So think the opposite of that, and that's what these medications will do to the heart. Now, what are some important things the nurse should monitor in regards to administering beta blockers? Prior to administration, we need to check what? Our client's heart rate and blood pressure. Let's say our client's heart rate is less than 60 beats per minute, or the systolic blood pressure is less than 100. What do you think? We'd absolutely notify the provider for an order to hold these drugs, as they're just going to drive it down even further, causing potential harm to our client. But that is why it's so important to know what specific medications can do, and always, always, always have that critical thinking hat on. All right. Do you remember that there are different types of beta receptors in the body? For our purposes today, we're going to focus on beta 1 and beta 2 receptors. Selective, or sometimes referred to as cardioselective beta blockers, only block those beta 1 receptors that primarily impact the heart muscle. So think beta 1, we have one heart. So they aren't going to impact the beta receptors found elsewhere in the body. Example of these are going to be our atenolol and metoprolol. Non-selective beta blockers such as labetalol and propranolol, on the other hand, these are older and non-specific, so they'll block beta 1 and beta 2 receptors, which will impact the tissues in the lungs, vasculature, and kidneys. So those beta 2 receptors in the lungs, when they are blocked, actually cause the airway to narrow. So remember that by thinking beta 2, 2 lungs. So, which conditions might we need to avoid beta blockers in, as it could make the conditions worse? Respiratory conditions like asthma and COPD for sure. One other thing to keep in mind is that when a client is hypoglycemic, norepinephrine will induce tremors and a rapid heartbeat and other symptoms that we think of in hypoglycemia. So, if we block those receptors and consequently block those effects, the signs and symptoms of hypoglycemia might be lessened or even masked within a client. So, this is something we absolutely need to educate our clients who are diabetic on. All right, let's go ahead and wrap things up with a practice question. A client is admitted to the medical surgical unit and is due for their dose of metoprolol at 9 o'clock. Which finding would cause the registered nurse to hold this medication? Would it be a serum potassium of 4.2, a heart rate of 58, a blood pressure of 112/78, or a respiratory rate of 23? What do you think here? Go ahead, take a minute, pause if needed before we talk about the correct answer. All right, our answer is going to be B, a heart rate of 58 beats per minute. Remember, we would hold a beta blocker if the client's heart rate is less than 60 or the systolic blood pressure is less than 100. The other answer choices are all within normal limits, so no need to hold the medication with those. Thank you so much for joining today. And really, this is just scratching the surface of beta blockers and calcium channel blockers. We have a ton more information within our crash course on these two drug classes. So check it out if you haven't already. Happy studying. I know you can do this.